Our next speaker is Professor Penanfrancia Cano from Philippines. She's associate professor of Department of Anesthesiology and head of section of orthopedic anesthesia of University of Philippines General Hospital. She also a consultant of a Department of Anesthesiology and at the Asian Hospital and Medical Center at San Juan de Dios Hospital. She's a member of the board director and the chair of the CME Committee of Philippine Society of Anesthesiologists. She's a formerly an associate professor of biochemistry and molecular biology at the same university, and she is also the former section head of ambulatory anesthesia at the Philippine General Hospital. Like Dr. Amir, she holds a European Diploma in Regional Anesthesia (EDRA). The Cano is also one of the pioneers of ultrasound-guided nerve block in Philippines. She has spearheaded and directed several conferences and workshops all over the country, and she's a respected speaker both locally and internationally. Ladies and gentlemen, Professor Penanfrancia Cano.
Good afternoon, everyone. Well, if Dr. Shinichi Sakura has a couple of temples and some spa in his country, well, in my country, we are famous for some very nice beaches. In fact, Dr. Karmakar and Dr. Sakura has been to one of them. So, just like this very calm nature attraction in my country, it's a very famous island. This is in Coron in Palawan. We as anesthesiologists, we also would want our patients to be calm in the sense that we would want them to have a low Apgar score. And one of the methods that we apply for analgesic post-operative analgesia is the epidural. The epidural is considered as the gold standard in post-operative analgesia. But there has been a plethora of cardiovascular and pulmonary and even infectious side effects. Added to that, although epidural can reduce cardiovascular and pulmonary morbidities in patients who are at high risk for surgery, there is also a lesser need for the epidural. Why? Because of the advances in surgical techniques that now require fast track embolization of the patients. And in fact, they would require now the patient to be discharged right away. They don't have to be admitted. And with the widespread implementation of prophylactic anticoagulation, there's no warrant for the need for epidural for postoperative analgesia. Alongside with that, there's now no evidence of decreased postoperative mortality, and even there's hardly any manifestation of cost effectiveness that is associated with the technique. Also, some anesthesiologists would not use epidural anymore because of the risk of neurological complications that could end up in litigations. There's also an increasing evidence of better, safer alternatives to epidural. We have paravertebral block, which has just been discussed by Dr. Kamakar. We also have nerve blocks for upper and lower extremity surgeries. And we also have wound catheter infusions for a variety of surgeries. I was supposed to include here the PEX block because in my experience, I don't use any more paravertebral for breast surgeries. It's a very simple technique, it's effective. I've done it on bilateral breast mastectomy, and it's a very good block for me. We also have different types of blocks for abdominal surgeries. So considering all of these factors, Dr. Narinder Rawal, who is once a president of ESRA and a Carl Kohler awardee, posted this question in one of the articles of the Regional Anesthesia Journal, which is epidural technique for postoperative pain. Is it still the gold standard? A substantial amount of pain that is experienced by patients after abdominal surgery is secondary to the abdominal wall incision. As we all know of, the abdominal wall, the lateral abdominal wall, consists of three layers. We have the external oblique, the internal oblique, the transversus abdominis. If you would look at it simply like this, we would see the skin and the subcutaneous tissue over here. We have the three layers, and below the transversus abdominis would be the transversalis fascia and then the peritoneum. So that we should make it a point when we do this block, these blocks for the abdominal wall, that we should always see the needle, because if not, we might end up with the needle being in the peritoneum. In between the internal oblique and the transversus abdominis muscle is where the nerves that would provide sensory innervation would pass. This is called the top plane, which is short for the transversus abdominis plane. Also, part of the abdominal wall is the rectus abdominis. The nerves that provide sensory innervation are from the anterior rami of spinal nerves T6 to L1. All of these nerves would give out a lateral cutaneous branch in the mid-axillary line, and they would ascend subcutaneously up to the anterior axillary line. So they would provide sensory innervation to the lateral part of the abdomen, which is here. They would also give out the anterior branch, which would pass between the internal oblique and the transversus abdominis muscle. We should take note that the T6 to T9 nerves would enter the top plane medial to the anterior axillary line at the costal margin, whereas the T10 to T12, they would enter the top plane lateral to the anterior axillary line. Now, these nerves is not just a line of two or a strand of two, but rather you would see here that there is a network of nerves here, which is probably the reason why patients would feel a lot of pain after an abdominal surgery. These are the different types of abdominal wall blocks. Let us start it off with the transversus abdominis plane block, which is simply called the top block. It is a simple, ineffective technique for abdominal surgeries where a lot of pain that is involved is parietal. The top block does not cover or does not block the visceral part of the pain, so that you have to do a multimodal analgesia in combination with your top block for a more effective postoperative analgesia. In For a simple landmark, basically, we do a top block by placing the linear transducer between the iliac crest and the costal margin. And this is what we are going to see. We have the three layers, and then we will put our local anesthetic at the top plane. So this is how it would appear with the ultrasound machine. And this is how we will do it. First, let's identify the three layers. This is the external, the internal oblique. You can see that the transversus abdominis is very thin, and over here will be the viscous. Let us watch how I did it in one of my patients. So you can see the needle getting in. There's a pop. When you feel that top plane, you will feel a pop, and then you can inject the local anesthetic. You don't have to move your needle because the local anesthetic will just spread through. Top block, there are so many journals, articles that have been written regarding its use. It has been used post-cesarean for post-cesarean patients in laparoscopic surgery, in all sorts of surgeries actually. It has also been used for iliac crest bone graft. It may also be handy for patients like this. I have a patient who weighs 120 kilograms. She was scheduled for radical hysterectomy with bilateral lymph node dissection. Would you put an epidural on this patient for postoperative pain management? Yes or no? Yeah, she's 120 kilograms. So I did a general anesthesia. Then, before I extubated the patient, I did a bilateral top block that is in combination with multimodal analgesia. I had a zero vascor at the recovery room. So that was at the recovery room. But as we would go on, you would see, or you would be able to differentiate a top block from other types of blocks in the abdominal wall. So there was a study done by Abdallah and Brule where from their study they said that not all top blocks are the same, which is indeed true, because the point of needle insertion and the pattern of spread of the local anesthesia would matter a lot. This was confirmed by Carney, McDonald, and colleagues, where they also made a study on the spread of the local anesthetic. And they did a study on four different types of abdominal blocks. The first block is the lateral or the classical block. For this block, you place your linear transducer at the mid-axillary line and then you inject your local anesthetic at the area of the anterior axillary line. And based on their studies, the pattern of spread of the local anesthesia for this type of block, if you would look at it, it was only concentrated within that area where they inserted the needle. And then the dermatomes that were covered were T10 to T12, which are nerves that provide sensory innervation to the infraumbilical region. So this type of block is very appropriate for lower types of abdominal surgery. Now, you would ask, can it also block the T9 dermatome? Yes, it can, T9 and L1, but it can block that dermatome less than 50% of the time. The second block technique that they studied is the subcostal approach. This block demonstrates an effective block that would cover the supraumbilical area. As I have previously mentioned, the nerves in this area, the T6 to T9 nerves, would enter the top plane medial to the anterior axillary line adjacent to the costal margin, so that you should place your linear transducer adjacent and parallel to the costal margin. Now, the top in this region, the top plane, is said to be between the rectus abdominis and the transversus abdominis muscle. The external oblique and internal oblique would come out as an aponeurosis in this region of the abdomen, and it would later contribute to the rectus sheath. Now, if you will inject your local anesthetic lateral to the linea semilunaris, you will have a block of T10 to 11. But if you desire to block the level of T6 to T8, you should inject your local anesthetic medial to your linea semilunaris and as close as possible to your xiphoid process. Now, based on the pattern of spread that they studied radiographically, it is difficult really to block the T6 to T7 dermatome. In fact, it fails more than 50 to 70% of the time. And since you are doing this block as near as possible to the rectus abdominis or the syphis sternum, it does not block the lateral cutaneous branches, so that there will be no analgesia for surgical incisions lateral to the anterior axillary line. Niraj and colleagues did a study comparing the effect of continuous epidural from continuous subcostal top plaque. And what did they found out? Based on their findings, the VAS scores of patients at different time points were not significant, whether the patient was coughing or at rest. The epidural group, however, had a success rate of 78%, while the top catheter group had a 63% success rate. And why was there a lower success rate? They attributed it to the uncontrolled pain based from the incision beyond the anterior axillary line, which is lateral to the anterior axillary line. And there's also the inability to cover the visceral pain. But in any ways, there's no significant advantage of epidural over the subcostal top block. The third top block technique that they studied is the landmark technique, wherein you put your local anesthesia in the triangle of Petit, wherein the landmarks would be, we have the latissimus dorsi posteriorly, and then the external oblique anteriorly, and then inferiorly we have the iliac crest, so that you are in that area of the posterior axillary line. With the patient in the supine position, your needle will be placed perpendicular to the skin, and then you should try to feel for two pops and then you inject your local anesthetic. Then they found out that this is a very effective technique because the pattern of spread of the local anesthetic did not only concentrate in that area of the mid axillary line, but it went towards that area of the quadratus lumborum muscle, the psoas muscle, the thoracolumbar fascia, and even the paravertebral space. It can produce analgesia from the level of T7 to L1, so that this is a block that was not seen in the two previous blocks that we have mentioned. The fourth block that they studied is the posterior block or the quadratus lumborum block, which is simply called as the QL block. This was first described by Dr. Rafael Blanco in 2007 in one of the ESRA meetings. This block promises an extensive analgesia, just like the landmark approach. It became so popular from that time on, so that we know that the top block has a very limited coverage of analgesia. What is vital is for the local anesthetic to go beyond the top plane and go to that area posteriorly where the quadratus lumborum, the thoracolumbar fascia, the psoas muscle, and it would eventually go to the paravertebral space. We can do this block with the patient in a supine position or also in the lateral position. A lot of anesthesiologists would prefer the lateral position because there's more leverage in terms of your convex probe, your needle, and also there's a better visualization in terms of other structures. As you would move your probe posteriorly when the patient is in a lateral position, you'll be able to visualize the tapering of the three abdominal muscles. And then we will have the transversalis fascia and then the quadratus lumborum. The quadratus lumborum muscle is enveloped by a thick fibrous thoracolumbar fascia. This thoracolumbar fascia is still subdivided into three layers. We have the anterior layer. In this part, we have the thoracolumbar fascia layers with the muscles, and this one, you can only see the facial layers. So the quadratus lumborum muscle is enclosed within that anterior thoracolumbar fascia, whereas the middle layer is the one that is between the quadratus lumborum, this one, and the paraspinal muscles. And then the third layer would be the posterior layer. What separates the psoas muscle from the quadratus lumborum is the anterior portion or anterior layer of your thoracolumbar fascia. The middle and the posterior layer would fuse together, and it will also fuse together with the transversalis fascia, which envelopes your transversus abdominis muscle, along with the aponeurosis of the internal oblique. And this is called the lateral raphe or the lumbar interfacial triangle. Even if the facial layers are described separately for the thoracic and the lumbar region, the paravertebral space between the two regions are interconnected. In fact, Dr. Karmakar has reported it in one of his papers wherein he did a paravertebral block and there was a connection towards the abdominal cavity. But I did not show it anymore, but I just mentioned it because I want you to know that there's really a connection of the paravertebral spaces between the thorax and the lumbar region. And this is through the medial and lateral arcuate ligament. Now, this is perhaps the reason that would cause the local anesthetic if you would inject it at the area of the quadratus lumborum, where your thoracolumbar fascia is located, it would have a connection towards the thoracic region. Now, there are three methods of doing a QL block. The first and the second have been described by Dr. Rafael Blanco. The first approach, which is the QL1, is the direction of the needle is anterior to posterior, and then you inject your local anesthetic at the anterolateral border of your quadratus lumborum muscle, which is at the area of the lumbar interfacial triangle. The QL2, the position of the needle is also from anterior to posterior, and then you place your local anesthetic at the dorsal area of the quadratus lumborum. At that space between the quadratus lumborum, where your middle thoracolumbar fascia is situated, so it is between the quadratus lumborum and your paraspinal muscles. Whereas the QL3, which has been introduced by Dr. Jens Borglum from Denmark, it's on a deeper plane, which is between the quadratus lumborum and the psoas muscle, and the needle is directed from posterior to anterior. So based on their studies, on their radiographic findings, the local anesthesia would extend as far as the quadratus lumborum and the psoas muscle and the paravertebral region, and it can achieve an extensive block from T7 to L1, and also it would produce a longer duration of analgesia. So now we found out that the quadratus lumborum block really imitates the pattern of spread as it is with the landmark approach. Murucci and colleagues did a study comparing the effect of quadratus lumborum block from the top block in patients who had laparoscopic surgery based on the duration of analgesia and the extent of the dermatomes that have been blocked. Based on his study, he was able to conclude that the duration of analgesia for the QL block is longer. It was more than 24 hours. It's already on the 24th hour, but still, you have a very good analgesia with the quadratus lumborum block. But when it comes to the top block, it only lasted for 8 hours. So the duration is very short. It's effective, but only with an 8-hour duration of analgesia. As with regards to the dermatomes that have been blocked, for the QL, the dermatomes were from T7 to L1, whereas for the top block, it's a lateral classical approach. The dermatomes that were blocked were only from T10 to L1. Now, Dr. Blanco had a paper that was published in the RAPM journal in 2016, where he compared the QL block from the top block for patients who had cesarean section. Based on his findings, the duration of analgesia in the QL patients were 48 hours, and it was only 8 to 12 hours of duration for analgesia for those patients who had a top block. The patients in the QL group also had a less morphine consumption as compared to the patients who had the top. His theory is that the analgesia is more because of the pain and mechanical receptors that are contained in the thoracolumbar fascia. He also claims that these receptors are very near the blood vessels so that they have some form of sympathetic effect. Based from his previous study, he said that there's a very little amount of local anesthesia that would spread towards the paravertebral space. So he recommended that since the true mechanism of action of the quadratus lumborum block is still really unknown, more studies should be done. Now, based on the study that was done by Lee, Hebbard, and colleagues from Australia, their conclusion was that the subcostal approach is better suited for upper abdominal surgery, while the lateral classical approach is more appropriate for the lower abdominal surgery. And for Dr. Carney McDonald and colleagues who studied the spread of anesthesia based on the four techniques, their conclusion was that the site of deposition of the local anesthetic would substantially influence the spread pattern, and that the posterior approach mimics most closely the posterior approach, which is the QL block, the deposition pattern seen with the landmark guided approach. Now we go to the next block, which is the rectosheath block. We know that the nerves that would go through the top plane would go anteriorly, but before doing so, they would penetrate the rectosheath, then the rectus abdominis muscle, and then they would end up in the skin as the anterior cutaneous nerve to provide sensory innervation to the skin in the central part of the abdomen, including the rectus abdominis muscle. So if you inject your local anesthetic just posterior to the rectus abdominis muscle, you'll have a dense analgesia in the central part of the abdominal wall. You should do it bilaterally. This block, based on several studies, have been proven to be effective for midline incisions. Now we go to the very popular block for pediatric patients undergoing inguinal surgery, which is the ilioinguinal iliohypogastric nerve block. They are derived from the L1 nerve. They would pass lateral to the psoas, to the border of the psoas muscle, and would pass obliquely at the area of the quadratus lumborum and then the iliacus muscle. It is just under the iliohypogastric nerve. These nerves would then go above the anterior superior iliac spine and they would traverse the top plane, but as they go more anteriorly, they would become more superficial and pass in between the internal oblique and the external oblique muscle. The iliohypogastric nerve would provide sensory innervation to the hypogastric area, whereas the ilioinguinal nerve would provide sensory innervation to the base of the penis and the scrotum. But for females, it would provide sensory innervation to the labia majora. As a resident, I don't know with you guys when you were residents and when you were doing your landmark approach for ilioinguinal, iliohypogastric, we would do it like we would look for the anterior superior iliac spine and then we would measure 1.5 centimeters medial to that and then 1.5 centimeters cephalad, but others would do it 1.5 centimeters caudal. But if you would look at textbooks, what they would do is they would divide into three that area from the anterior superior spine to the umbilicus, divide it into three-thirds, and the most lateral third will be the area where you will do your needle puncture, and then you should discern the first pop and then the second pop because the second pop would be that plane between the internal oblique and then the transversus abdominis muscle, and then that is where you inject your local anesthetic. Now here comes my question. Where does exactly your local anesthetic go when you do it like this? Are you sure you are in that top plane? How many are sure that you are in the top plane because you are just doing it by feel? So if you have a smaller needle, it's hard to detect the second pop. It's better to use a bigger needle so that you can detect the second pop. But now that we have the ultrasound, it's not a problem anymore. So there was one anesthesiologist, Weintraub, Marhofer, Capral, they are from Austria, who tried to investigate where exactly does the local anesthetic go when you inject it blindly. So among the 62 patients, it was only in 14 patients wherein the block or the local anesthetic was delivered in the right space, which is in the top plane. In 86% of the cases, they were injected somewhere in the iliac muscle, transversus abdominis muscle. But since for those who were injected in the area of the internal oblique, transversus abdominis muscle, they still came out as successful because only 45% failed. So their conclusion was that accurate placement of local anesthetic around the nerves in children is seldom possible with the landmark techniques. Now, if you're doing it blindly, there could also be complications, just like these cases that have been reported. There have been report of transient femoral nerve palsy, iliac compartment block, And then colonic puncture. That's the worst. So when I do my ilioinguinal iliohypogastric nerve block in pediatric patients, I begin by placing the linear transducer just above the anterior superior iliac spine. And from there, I would move my probe medially and then look for the nerve. And here it is. You can see this is the external oblique. Internal oblique, the transversus abdominis muscle is very thin. This is a 5-year-old child. Over here would be the viscous. So I do it from lateral to medial. And this is how I did it. So my target is over there, in this area. Where is it? It's over there anyway. Since I did it on a pediatric patient, um, you might not be able to understand very well the image. So I did it in this patient who had orchidopexy. I asked the mothers of several patients that I'll take their photos. So they were not crying. They were calm, just like the tourist attraction in my country. So no violent reactions. And also this child, orchidopexy, this child, hernia. So based on the study of Vilche and colleagues, he tried to analyze, because with the landmark approach, our dose is zero point 0.3 to zero point 0.5 cc per kilogram of 0.25% levobupivacaine or bupivacaine. They studied how far can they reduce the dose also with an effective ilioinguinal iliohypogastric nerve block. Based on their study, you can go as low as 0.075 cc per kilogram. That is already for both nerves. You just inject on one side and then it will just diffuse towards the other nerve. And the success rate for this is 100%. But the problem with this very low dose is that it will only last for 4 hours. So in my case, so that the mother and the child will be happy, I still go with zero point 0.2 to zero point 0.3 cc per kilogram of 0.25% local anesthetic. Now, before I end, I'm inviting all of you to attend the Restorative and Alternative Medicine Conference in November in Vienna, Austria. And this is just a food for thought. According to Dr. Denny, he's from somewhere in UK, that regional anesthesia always works provided you put the right dose of the right drug in the right place. Thank you.
Go, Prof. Penanfrancia, Cano. Is there any question from the floor? Any burning question? Because very difficult to get our speaker from one from Hong Kong and one from Philippines, and very good speaker. Okay, if no question, I give it back to our chairperson.
I would like to invite Dr. Aminuddin to give the token of appreciation to the speakers.
Can you connect this? I don't want to break your VGA because I've done it before.
You want to do?
If you press the wrong button, it goes all the way in. So
Dr. Penanfrancia.